will take the advantage of that and say that how privileged and honored we are to have you on this talk, and we welcome everybody that is just joining us. I want to mention to everybody that if Dr. Diamond have an extensive clinical and technological experience, and any question related directly or indirectly to the talk, please feel comfortable and welcome to type in on the chat your questions, and Dr. Diamond will respond at the end to as many that time will allow. And I want again to welcome everybody and welcome you, Dr. Diamond, and the floor is yours. Thank you very, very much.
Thank you very much. It's a pleasure to be here today. And I think with this forum, I don't really mind. Sometimes it gets crazy on Zoom, but we could respond to questions as they're being typed. I may miss them, or I don't mind if you guys interrupt me at any point, and I'm glad to stop and talk. I'd love to have more of a dialogue rather than just lecture. So please stop me at any point with this. I'm not just wearing my doctor's costume today. I still practice medicine outside of Pittsburgh, Pennsylvania, a couple days a week. I've been in family practice for about 30 years, which is hard to believe, which means I'm seeing children's. I've seen 3 generations of patients nowadays. But I got involved in medical information technology early in my career as an early adopter, I would say, not because I was interested so much in technology as because I was interested in how to improve the way that we deliver care. Back a couple decades ago, as I started getting more involved in this, just my background, I did some due diligence on an Israeli company that was being considered for investment from the University of Pittsburgh Medical Center, which is DB Motion. I sort of got into this whole world of technology, information technology, Israeli technology. And that company later, as we moved on and sold that company, got into the genetics field because we saw a similar problem with that. And that genetics field has moved very, very rapidly. In fact, much quicker than anything else that I've seen in medicine in my entire career. And so the title of this talk as the standard of care, some people are still thinking this is an emerging technology. But as we'll talk about, I think that time is come and gone already. I think we truly are in the standard of care with this. So let me see if I could advance my slides here, and I hope you are seeing them. I think the biggest interest and why things have changed has been this consumer interest. And unlike other technologies in the past where medicine's far out in front, and then we convince consumers, we convince patients that this new technology is the way to do something. It's the other way around now. So most people have heard of 23andMe or have had their ancestry checked, or as you could see, there's a company, Helix, up on the slide now. This is actually a company that will test your DNA and match it with what preference of wine you might have. So we've come into sort of the crazy part of this, and I'll still say it's crazy. My wife decided to have Ancestry.com done a few years ago, and I pleaded with her to save my money because I told her, when you get that test back, I most certainly will be 99% Ashkenazi Jew. She was much more fascinated with the 1% Irish that she had, which undoubtedly explains her blue eyes. But other than that, not a lot of intense medical information from that. But I think where things have changed a lot is really in how does this affect how we take care of patients, how we can identify disease earlier, and celebrity things like Angelina Jolie a few years ago, recognizing that she had breast cancer that had a genetic basis in it, I think did a lot for consumer awareness, but also changed the way that doctors think about this. And in fact, if we look at the BRCA gene and its effect on breast cancer, it's still very underutilized nowadays. But on the other hand, if we look at the number of people that have had BRCA testing, the increase over the last couple of years is incredible. Is there a question? Just some background noise. So let's talk about breast cancer in general. And the BRCA gene is really a marker for breast and ovarian cancer. We've done a lot, at least in the United States, to screen for breast cancer. We have a Breast Cancer Awareness Month. We have a Susan Komen Walk for the Cure every year, and raising a lot of money for breast cancer. But where do we still need to make the inroads? So I'll share with you a story of mine. A few years ago, I had a young nurse who came to see me for a routine physical exam, and she was very healthy. There wasn't much wrong with her. I asked her about her family history, and she became very, very nervous. She said, I don't really want to talk about it. And we talked a little bit more, and she told me her mother died of breast cancer, but her maternal grandmother died of breast cancer, and her mother's sister died of ovarian cancer. And multiple other members of her mother's side of the family had both breast, ovarian cancer, in fact, some other GI cancers as well. And she said to me, please don't go where you're going to go. I know that there's a genetic risk. I don't ever want to have that test done. I don't want to find it out because I'm afraid that I'll have to have surgery and have a double mastectomy. And I said, let's take a time out. There's a lot more we could do besides that. And we could do some more intensive screening, et cetera, et cetera. So I talked her at least into having her first mammogram. And this is where a doctor that's in primary care like myself feels some days like you have a knife going through your heart, because her mammogram came back with stage 2 breast cancer. If you could see down at the bottom part of the screen, one of the recommendations was that she get genetic consultation, which is almost ridiculous at this point. So where I live and the hospital where I practice has been continually named one of the most wired hospitals in the United States. And we have all these policies and procedures in place for reducing errors and screening, et cetera. And it's almost unconscionable to me that a young woman like this could have slipped through the cracks, that we couldn't find or counsel her early on and really do something positive, let alone the fact that she has 2 sisters and a daughter who also now are at high risk for this. So now you could start seeing, how do we move this into the general practice of medicine? We all know if you go to a hospital or a doctor's office, you get asked 100 times what allergies you might have, and they put a band on you, and before they give you a drug, they ask about allergies again. And we've almost completely nullified allergy-related deaths, at least in the hospital system, because we're so careful. It doesn't mean they don't happen, but they're very, very rare. But yet these other areas that we're moving into, particularly drug safety, identifying other illnesses early, we still need to make some bigger inroads in. So let's talk about genetics for a second. I don't know how many people on this call have some basic genetic understanding or not, so I'll try not to talk at too high or too low a level right now. But the genetic code, as all of you know, is made up of these 4 base pairs, these G's, these A, T's, and C's. And those base pairs, the coding of all those, the combination of those, tell us certain information and code for genes. But the human genome, which was fully uncovered in 2003, is pretty big. In fact, it's 3 billion letters long. And so that's a lot of code to unravel. And there's a lot of information in there, but there's still a lot of information that we don't know. We have figured a lot of cool things out. I talked about BRCA as a risk for breast and ovarian cancer. We're understanding that there's a basis of things like Alzheimer's disease and other illnesses like that, emerging evidence about autism and what the genetic factors and roles may be played in that. And then how do certain drugs get metabolized different for different people? We know that as well, and starting to use pharmacogenomics in the routine care of our patients. I mentioned that the Human Genome Project, which was completed in 2003, that project took about $3 billion to do. So $3 billion, 3 billion base pair, about $1 a base pair back then. For those of you who are familiar with Moore's law, that's the law that looks at both the cost and the change, exponential change in technology over time. Genomics has defied that law, and it's one of the first times technology in my life has done that. So in fact, a test that cost $3 billion in 2003 is now coming down below $1,000 and predicted to be around $100. In fact, there's a commercial company right now that is offering a $300 pretty advanced entire genome sequencing. So you could see they even advertise that as, you know, think of what you're getting for your $150 23andMe test, which is just some, what I'll say, party tricks, knowing stuff about caffeine and red hair and some other things, as opposed to knowing your entire genome for not that much more money. And now you could see where the consumer interest in this may be outpacing what's really being done by doctors on a routine basis. So I'll stop a second and take another step here. This is actually a genome sequence of a real life human being. It happens to be, that human being happens to be me. So these are all my genes, and you could see the 23 pairs of genes that I have, including the X and Y chromosome at the bottom. But you'll be interesting to know that they sequenced about 45,000 variants in me. It's a lot. But of those variants that we know about that are associated with information, there was exactly 3738. So almost 4,000 known variants in me. So that's a lot of information. What did I do with that? Well, if I look at those findings, they break down like this. First of all, of the 3,700 genes I had, 33 of those were pathological. And this is a really interesting part, because you may wonder how I could be sitting here talking to you if I had 33 pathological findings. And the answer to that is what most of you know, is that cause and effect are very big different things. The fact that I have a gene doesn't mean it's going to express itself. It just means I have it. And there are many, many things that go into that actually turning into disease. In fact, most of these 33 conditions are diseases of childhood that luckily I don't have. I could look back and say I passed that. But with everything, there's a little bit of a caution to that. So for instance, one of the genes is one that codes for a disease that's common amongst Ashkenazi Jews, in fact, is Tay-Sachs disease. And although nobody in my family or I had Tay-Sachs disease, I do have that particular gene variant. And lately, there's been some studies looking at that gene variant as perhaps a risk factor for Parkinson's disease. So, you know, you can't always outgrow these things because of the multifactorial way that they treat us. I do think it's interesting how we talk about the classification as pathologic or likely pathologic. I actually tell people all the time that I'm more frightened by likely benign. I don't know what likely benign means. I know what pathological, but really what worries me is the one in the middle, the variants of unknown significance. Those are genes that we know there's something wrong with them, but science hasn't really caught up with them. And so I had about 87 of those variants of unknown significance. This was many years ago that I had this test done, and I bet that number has decreased because science has probably caught up with that now and know what some of those genes represent or don't represent. So you could ask me, did I find anything interesting in here? And I did. I found some interesting things about which drugs I metabolize better than others, and susceptibility to certain illnesses. I was most interested because I have a family history of a certain type of heart condition, a cardiomyopathy. And in fact, I had a positive gene just in the area that I was most afraid of with that. And although I don't have any symptoms, I did say, I'll take this as an opportunity to get some cardiac testing done. So because I'm a doctor, I went, saw my friend who's a cardiologist, and I said, hey, can you do an echocardiogram on me? Look at my heart, make sure I don't have cardiomyopathy. While you're at it, why don't we just do a stress echo, because I'm there, and just make sure I don't have any coronary disease, even though I'm asymptomatic. Long story short, I don't have cardiomyopathy, but I did turn out to have a 70% lesion in my left anterior descending artery, which is what they call the widowmaker. And so my genetics, although directly didn't lead to something I could do to improve the longevity and quality of my life, it did indirectly. By the way, when we talk about that Widowmaker in the cath lab. You can't see it here, but behind those people, there's a glass booth there. And while I was finishing up my procedure, I was talking to the nurse, and I could see my wife talking to the cardiologist who we're friends with. And I could see her talking very animated and loudly. And the nurse turned to me and said, "I wonder what they're talking about in there." And I said, "I could most certainly tell you what they're talking about. My wife at this moment is just telling him why I'm not eating another piece of red meat. I'm not going to drink another glass of scotch, blah, 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 blah." At which point my wife turned to me at the glass and gave me an obscene gesture through the glass. And the nurse said that she forgot to mention to me that there was a microphone in the room and my wife could hear everything I was talking about. But we can move on from there. Let's talk about pharmacogenetics and what that means. So one area of the genome has to do with how we metabolize certain medications. And it turns out that this explains a lot why when we give the same drug to multiple people, some people the drug will actually work and do something therapeutic, and some people not. But even within those two cases, some people will have side effects and other people won't. So we sort of divide the world into these four categories. And why? Worse than that, if we look at some major releases of drugs, particularly in the last decade or so, where they were very successful drugs, a drug many of you may remember from about 10 years ago called Vioxx, which is an arthritis drug that was supposed to be safer than some of the common meds we use today, like ibuprofen, had a great safety profile in clinical trials. And then 2 years after it was into use, found out that it was causing heart attacks in certain individuals and was pulled from the market. And I would maintain the reason for that is those clinical trials don't typically look at pharmacogenomics, and they're not dividing people that may, in fact, have a different way of metabolizing that drug. So the list of drugs that pharmacogenomics play a role in are huge. We participated not that long ago in a corporate offering to healthy employees who wanted to sign up and see if they had any issues with drug metabolism currently or in the future. So there were about 1,000 employees, healthy employees, of those patients taking behavioral health medicines, drugs for depression or anxiety, which was somewhere about, I think, 20% of the population. About half of those people had a serious issue with that drug either not working properly or having side effects. The same was true with some pain medicines, and it was especially true in some cardiovascular medicines. So you could start seeing, if you apply that to a healthy population, imagine when you start getting into patients who are on multiple drugs, et cetera. Part of my company's technology is to be able to make that expressed easily for a physician at the point of care, meaning that when I see a patient in front of me and look at their medication list, it could be broken down in a sort of red, yellow, green format where I could see that in this case, this common antidepressant drug that you're seeing here, Celexa, actually is probably a bad choice for this patient, or this Plavix, which is a drug that we give to everybody that's had a cardiac event to reduce the risk of having a second cardiac event, in fact, doesn't work at all because the individual metabolizes that drug too quickly. So in my own clinical practice last week, I saw a young woman whose parents I've been taking care of for a long time. She's now in college, and she has suffered from depression for a number of years, and has almost given up, not in terms of suicide, but feeling like nothing's going to work for her. She had been on multiple medications without effectiveness, and her parents asked her to see me because they know me. First thing I did was a pharmacogenomics test, like you're seeing here. The current drug that she was taking, in fact, turned out red like this. She was a rapid metabolizer, so it was not going to work. The previous drug that she had taken was metabolized in such a fashion that it would take nearly 12 weeks before she would reach a therapeutic level. So she took this drug for 4 weeks. It didn't work. The dose was increased. And after 8 weeks, she gave up on it. And maybe if she waited 3 months, but even that sounds ridiculous. So now using pharmacogenomics, it's really easy to pick a medicine for her and say, listen, you're not a patient with treatment-resistant depression. In fact, there are many, many medicines that work for you, but let's stop this trial and error approach to treating you. Let's be much more scientific. Let me pick one of the medicines that I know that you at least have a fighting chance with. And that goes down through the list. And nowadays, my patients on antidepressants or anti-anxiety medicines, I may treat them by trial and error once, but certainly not a third time, and most of the time not a second time either. My elderly patients that are on multiple drugs, we're starting to see one of the reasons increase for falls or cognitive problems, or a cumulative effect, what we call a cascade effect of a drug causing a side effect and the side effects treated by another drug, et cetera, et cetera. And we start seeing people on multiple drugs with complications of those. Pharmacogenomics in that population is what I'll say is a no-brainer as well. In fact, many of the people that my colleagues that do this, about half of those patients in that category are going to have a serious problem with one of their medications, an adverse drug reaction that's related, in fact, to pharmacogenomics. So I'll switch gears here and talk about a whole other area, and that is cancer. So what's our traditional approach been to cancer? We classify cancers by their anatomic site. So somebody has lung cancer or stomach cancer or breast cancer or skin cancer or blood cancer. And we treat those cancers with radiation to destroy cells and hope that we kill more of the cancer than we do the rest of the body, or toxic drugs like chemotherapy with the same intent to destroy the cancer faster than the rest of the body, or we do surgery to remove that from that anatomical region. But again, much like I was talking about pharmacogenomics, why is it that there's such a variable response rate? Well, one of the reasons is that we know something like breast cancer, there's no such thing as just breast cancer. There's probably thousands of pathways that cause breast cancer. It's also the reason that some very, very rare cancers that there's a 100% cure for, because there's probably a single pathway to that disease. And once we find the right treatment for it, that's the only way to treat it. What we've learned over the last couple of years is this idea of classifying cancers by their anatomic site, in fact, doesn't make sense. What does make sense is when we biopsy that tumor and we send it to the lab, now just beyond looking at it under the microscope and doing certain stains on it, we're also sending it for DNA sequencing. And the behavior of that tumor and the genes that we find in the tumor are very different in many cases than the genes that we have inside our body. And by knowing those variants, we can specifically design treatment for that. So for instance, as you see in this slide here, lung cancer, a certain cell type of lung cancer called non-small cell lung cancer, if it has a number of different genetic variants in it, we can treat that with a certain drug. You see these advertised on TV now. Wonder why are they advertising chemotherapies on TV? And these are blockbuster drugs. So non-small cell lung cancer, which was not that long ago, a horrible prognosis to have. We know that there are medications now that can really drastically alter the disease-free survival of those patients. What's interesting is many of those drugs are also used to treat other cancers that in the past we thought had no relationship to each other. So in fact, if somebody has a KRAS or ESR mutation, we now base our chemotherapy on the marker rather than the anatomical site. And that's why now you're seeing that we're doing many things with genetics, including using this to locate more and more genes, where now you hear about immunotherapy. We're directing the body's own immune system to fight cancer by injecting altered T cells and things like that, or targeted therapy, like I mentioned before. And this has been the really exciting part of this, because in certain illnesses, melanoma as an example, certain types of breast cancer, I mentioned, certain types of lung cancer, et cetera, that this molecular DNA-based treatment has really changed the current care, and really looking forward, knowing that we're going to be doing this more and more in the future. Again, standard of care, not where we were not that long ago. And so again, in our technology, a doctor at the point of care can now see some of those findings and base treatment or even clinical trials based on those molecular finding, not what somebody's looking at under a microscope. And one last part of this is the era of what we call liquid biopsy. Liquid biopsy really means that we can now take a sample of the patient's blood and we could find minute amount of circulating cancer DNA in the patient's circulation. We could amplify that, and this now can identify new cancers or recurrence of cancers, et cetera. And it opens up a whole new era of how we treat people. Certainly the idea of doing a single biopsy, treating it, and then seeing what happens is probably gone by the wayside. Now we could start monitoring patients over the long term using this type of technology as well. Well, let me shift again. We'll get out of medication delivery, we'll get out of cancer treatment, and we'll move more towards the area on the other end of the spectrum, and that is before you're even born. So one is looking at this arc from prenatal counseling to maybe counseling involved in people that want to have artificial insemination, as an example, or planning for pregnancy based on family history, or during pregnancy. High-risk pregnancies, as most of you know, women originally had an option of maybe having an amniocentesis, putting a needle into the amniotic fluid, removing that, and look at some DNA capabilities within that. That technology moved to chorionic venous sampling a while ago, still somewhat of an invasive procedure, but safer. And then we've moved to non-invasive prenatal testing. Again, much like that cell-free DNA I talked about in cancer treatment, we can do the same. Find very minute amounts of peripherally circulating in the mother of the baby's DNA, amplify that, and then be able to do genetic analysis on the baby. And in fact, that technology has become so ubiquitous, at least in the States this year, finally, it's now been paid as part of routine care. So you can see the shift in how this technology is helping, but all the way through to babies being born and how we treat them in the NICU and how we treat them through the rest of early childhood and later. So that baby has this pre-printed formula for the rest of the day. And the idea is, as we look at that whole genome and the cost of it, why aren't we just checking that at birth? And the idea and the phrase we use a lot in this field is test once and query often. If I have your whole genome, I should constantly be able to look at it. So although as I go through my life, things may happen. I may develop a mole. I may have a certain cough. I might have another orthopedic condition. Can I look back at my genetics and say, is there something there that informs me? Or better yet, if I have those genetics, if I present with a certain symptom, can the genetics say to the physician, hey, by the way, you might want to consider this rare or otherwise rare disease in this? And that's really, truly where we want to be. As we look at this newborn part of it, let's talk specifically about in the neonatal ICU and where it makes a difference and where this is now becoming truly standard of care. In some institutions, they are running full genome sequencing, not on babies, but also to their mother and father. So this triad is being done early on in these kids. And in the beginning, people were saying, well, that's very, very expensive to do on everybody in the ICU. But neonatologists will tell you the frightening cost of a single day in the NICU. And these early interventions of doing whole genome sequencing on these children prove to do a lot. One of them is to make an early diagnosis of some of these newborn diseases. And some of those diseases, because they can make an early diagnosis, could significantly lengthen the length of time in the ICU and really drastically impact on the cost of care and that. Another example of that, seizures are very common in these kids that have unusual diseases of early childhood. And oftentimes, and we'll go back to the pharmacogenomics, but not because of pharmacogenomics, just because of understanding the disease. There's a trial and error part of prescribing these anti-seizure drugs, and oftentimes it may be the 6th or 7th drug that alleviates that child's seizures. By knowing the genetic problem that child has at the beginning, they can nail that in the 1st or 2nd trial. And so not only are we reducing time in the NICU and reducing cost, but imagine as a parent how different, what a different tone this has to be able to make an early diagnosis and treat these kids early on. So that's a really important part of this as well. We talk about rare diseases, and I think that's the part that's interesting because these diseases tend to be fairly horrible. But when we stack them together, yes, they're rare, 1% and 2%, but there are a lot of rare diseases. And when you start stacking them, that's a lot of kids and a lot of adults that suffer from these illnesses. This is Stephen Hawking. Most of you know, had a very rare form of ALS and managed to live a fairly quote unquote normal life despite a disease that often kills people younger. And understanding why that disease is different in so many people is a very interesting part of this. Unfortunately, I have friends of my family whose mother died of ALS at a very rather early age. Her son, who's about my age, 10 years ago was diagnosed with ALS and died relatively early from that disease as well. And just recently, his brother came down with ALS. So a very rare form of inherited ALS that's unique to their family, that's different. And this is a horrible, tragic disease. And yet, as we understand the genetic basis of this, most certainly will lead to a treatment for these diseases. I'm sure of this. But we have a lot of work to do before we get there. I'm leaving time for some question and answer here, but I'll just share with you this idea of cause and effect and what it may mean and how it's evolved in us in human beings. This is the CCR5 gene that I'm going to talk about. The CCRG is an interesting one. It's one that I have, and I found out incidentally in my genome. And one of the things retrospectively have been thought about this gene is it may be the reason that my ancestors survived the bubonic plague, that it coded for a protein on the cells that may have been protective of it. What's been interesting in the last couple of years is realizing that that gene causes a certain very low percentage of the world's population, hopefully myself included, to be resistant to contracting AIDS or HIV. So I often joke, I got that going for me, but I don't know really what that means in real life. But as you go through and you think of these things, some people thought that this gene may in fact offer some protection against getting COVID-19. I think that evidence isn't really clear right now, but we do know that there are variants in why some people get sick and why people get very, very sick and others don't at all. And it may be due to some genetic factors, may or may not involve this gene or not. And I'll leave you with one thought about, I use the expression, the Lord giveth and the Lord taketh away. Although I have this interesting gene and it may have helped my ancestors with bubonic plague and maybe in another lifetime would have protected me against AIDS. Recently, this came out, a study that says those with 2 copies of the CCR5 gene are 20% more likely to die by age 76. So go figure. Where these genes do one thing that's good and where they may do something bad is certainly an interesting factor. And it talks about, what populations they may have done some good and may not have. So I'm going to stop there. It's been a pleasure talking to you all today. It's hard to do this over Zoom, but I hope it's been interesting for you. And I'm glad to take any questions that you may have at this point. I'm going to bring up everybody's faces here, and we could either open up mics or I don't know, Ellie, if there were some chat questions as well.
I don't see any chat questions, but it was very interesting. And although it was on Zoom, it was very, very interesting. And I think it went through very well. So if anybody have a question to ask, either on the chat or just feel comfortable to open your microphones.
Hi, Joel. My name is Robert. Hi.
Hello, Robert.
I have actually a very specific and maybe personal question. I've been diagnosed twice with melanoma. After the excision, apparently I didn't have it anymore. And what attracted what you mentioned is how can I get this DNA sequencing to see what the future can bring? I mean, I'm not afraid of anything, but how do you initiate that? Is it the doctor that does it, or is it me that asks for it, or how does it work?
Well, it's a good question. It does tell you the variance of how our medical system is sort of slow to adopt this. So one is congratulations on surviving melanoma. That's the most important thing.
Yeah, I look like the whiskey brand Dimple, you know, with dimples in your head.
Well, we share the same barber, so our hair pattern's the same. So
okay.
I think that part doesn't matter. But if that's all that you have left, as you know, it's very frightening to have that diagnosis. So the most important thing is to say mazel tov to you, because congratulations, you certainly have done the important part of that. How long ago was it that you had your diagnosis?
The last one was 2 years ago, and before that I had an excision 6 years ago.
Okay, so your doctors may or may not have done that. This is different, as I mentioned, than the DNA that you have within you right now. It would have been on the sample that they took. And so when they excised that melanoma, they sent it to the lab. There was pathology on it. They may have, in fact, done a DNA sequencing on that test 2 years ago. Before that, they may not have with that. Nowadays, it becomes more the standard of care. There are markers within melanoma, one called BRAF as an example, that changes the treatment. But the reason that you may not have heard about this is, one is if your melanoma was superficial enough, surgery is still the preferred treatment. It wouldn't have changed any chemotherapy. You still may have had a course of standard chemotherapy before switching to one that was based on the DNA. So I suspect that you did so well that you didn't have a need to go that route. But if that sample still exists, yeah, they're still able, the DNA is still there, and somebody may still be able to send that for analysis in the future with that. But I think you got cured of your cancer, so you don't need to know those genetics. Congratulations on that.
I'm okay with that.
Yeah, okay. Exactly.
Sorry for the personal question, but it is
no. The personal part of it is why we're doing all of this. It's great.
All right. Thank you.
You're welcome. Anyone else?
Question? Yeah, I have a broad question. So I'm a little bit in the business that you described and spoke about. We are a CLIA lab that does next-gen sequencing specifically for oncology, and we have 4 Illumina machines, and you know the drill there. And we get all those sort of mutations or cancers, and we report them, both heme, liquid, solid, bone marrow, anything.
But, all right, you should have told me that before I started talking. Now I feel, yeah, that's good. I feel intimidated.
No. I learned from this lecture. Thank you so much, and I'll be reaching out to you afterwards. But good. In the general type of question spirit, the argument out there is sometimes to say, okay, if you specify the genes and there's already either direction what to do with it, or maybe even clinical trials we recommend. But if you find the genes that have an issue, but there is no known pathway these days about them, now that could be changing every day, as you know. How does what is the right thing to do? What is the right thing to do for the practitioner and the physician in terms of saying, okay, you have a problem, but we don't have the solution. So it's kind of a general high-level question. I'm just trying to hear your opinion.
It's a great question. It's one of the reasons that we decided to do the technology that we do, and that is that, and you know this, when your company does sequencing on a tumor and reports that back, most likely you're sending that in a report. It's a PDF or it's a Word document. Somebody reads that, and that's good for today. But as you mentioned, it's only as good. That document is only as good as the information today.
Yes.
Our company decided a long time ago that in all of other information technology, what we'd like to do is ask you to give us the raw data from your machine. Let me put that and store that in the cloud, and then allow the doctor or other people to do the interpretation of that. Now, that interpretation today may be very different than that interpretation tomorrow or a year from now. And so you're correct. There may be other genes on there that are today, we don't know what they mean or whether there's a therapy associated with it. But maybe I respond to my therapy, but I have recurrence of this a year from now.
Yes.
I would like to be able to resequence that, or I might want to requery the original data with knowledge that I have today. So that gets back to what I said before, test once, query often. I may want to rebiopsy this, et cetera. But that's the part that's missing, is the information technology piece of that, which is, and I'm not putting it down, but we sort of went backwards with information technology of having this come back as a paper document that serves to be used as a one-time piece. And then how do you get back to it? So my answer to your question is sort of what I've dedicated my company to, and in that is to liberate that data, recognize that the science is changing. I talked about the pharmacogenetics earlier, and you know what? As I see patients in front of me, there'll be a new drug that comes out tomorrow. How do I know if that drug goes against that? Or is there new information? So the way that I use my own technology in my own practice is exactly that. Every time I see a patient in real time, that drug list is being checked against their DNA, which is being checked against a real-time knowledge base. And those knowledge bases may change in the future as well, or there may be different knowledge bases and new nomenclature, by the way. And that's the other part, new vocabulary. So that's the answer to your question from my perspective, but you are correct that our current state of where most of this data is coming back as paper is continuing to be difficult.
Thank you.
So thanks for giving me a plug to talk about my own company.
Thank you.
Thank you.
My name is Udi Almon, and it's maybe a bit philosophical question. Actually, having all this data in very early age, still we are living in a very stressed world, you know, without speaking about SARS-CoV-2. So, and actually, I'll give you an example from the medicine field. People that have a brain aneurysm, it's as far as I know, it's they discover it by having check MRI or CT and by mistake. And then once they know that they have the aneurysm, they are thinking that they are walking or keeping living with nuclear bomb. So the question is actually how much you are going to share with the patient. This is one question. And the second question, it's about the cost. So when you're speaking about personalized, so you're speaking about the cost. And for instance, CAR-T, because you are familiar, we are speaking today about the price per patient of several hundred US dollars. There are even some Israeli companies that were working to have a point of care in the hospital to reduce the cost of several 10,000. But still, how this could go together? You know, what actually the system or the insurance company can provide to the average patient. Thank you.
Yeah, thank you, Ehud. They're both great questions. You know, the first one is, you know, you allude to this idea, maybe we can identify illnesses early, but I think one of the hidden part of your question is what will we do about some of them? You know, you mentioned aneurysms, and it's interesting from a genetic standpoint. there is a rare association with a genetic cause of kidney disease, polycystic kidney disease, that a certain percentage of those people will have brain aneurysms. And so people don't necessarily connect those things. I do think if I knew I had that gene, I would, or a patient of mine had that gene, I would certainly say if they presented to the emergency room with a headache, by all means, the first thing you should do is a MRI angiogram on that patient, right? You can make a difference with people. When I had my genome done, my wife said, God forbid, what if you find out that you have ALS, a terrible disease, what are you going to do? And I looked at her and I said, I know exactly what I do. I'm going to change my retirement portfolio. And that wasn't the answer she wanted to hear, but in fact, it's very, very true. I lived my life a very different way. But this still is a problem because we may do a genetic test to look for something, and then we may find something incidentally and not help people at all. They may choose to live their lives very, very differently. I had a patient who had a family history of Huntington's disease, which many of you know is an autosomal dominant disease. And he chose not to get a genetic test. But interestingly, he lived his life as an amazing, he was a very philanthropic. He did all these wonderful things. He said, I'm going to live my life to the fullest without it. Unbelievably, he died of a lung cancer that now there's a treatment for that was based on genetics, but this was about 10 years ago, which is just a terrible irony in all this. I think we need a long way to go with this. And one last example, and then I'll come down to the cost of this. I had a young woman who saw me that she told me her mother was diagnosed with pulmonary fibrosis. She was very worried about whether she could get pulmonary fibrosis, but her mother's doctor told her that it wasn't an inherited condition. She shouldn't worry about it. And she said to me, I don't know anything about pulmonary fibrosis, but I'll tell you that my mother had 8 brothers and sisters. 7 of them had pulmonary fibrosis, and I think your doctor's not right. And I said, I think your doctor's not right. There's 15% of people have inherited pulmonary fibrosis. And she said, well, should I have a test or not? It's an incurable disease. And she was in her 30s. And I said, listen, you have 4 decades before this disease may ever show up itself. You can participate in clinical trials. You can look for early signs and symptoms of it. And she said, well, I didn't think of it that way. So she ended up getting the test, and the test was negative. And she thanked me and said, thank God, now I can live my whole life not worrying about this. I did eventually tell her, well, it's not quite that simple. We may find new genes in the future that actually put you at risk, but at least for what we know now. But it is interesting. The cost factor that you talked about is an interesting one as well. And you look at all of medicine and where costs are and how they change things. So I'm old enough to remember when we started doing MRI, and MRI was so expensive compared to CAT scans, not just because of a new technology, but you had to have this magnet and you had to have liquid nitrogen and the facilities for it. It was a big deal. And yet we see the cost of that come down. And the idea of doing a PET scan on somebody where you need a nuclear accelerator to get this particle and do that now has become almost routine in the care of patients. Very expensive still, but the cost will come down. So I think we'll figure this out. If I look at pharmacogenomics that I mentioned, almost invariably we end up lowering the cost of care with the introduction of genetics in this case. I think we'll eventually lower the total cost of care in cancer, despite the ridiculous cost of some of these newer agents and therapies that you mentioned, mostly because people, well, they may live longer and cost the system more money, but that's ultimately our goal as well with this. But certainly less complications, et cetera. So I don't have a overall answer to the cost, but new technology is expensive and old technology isn't. And we're making great strides in medicine. So we'll figure it out. You see that the FDA in the US approved a new Alzheimer's drug that's insanely expensive and may not actually help many people because it's a disease that we don't have much treatment for. I think as we work towards more specific treatment, and more importantly, more specific diagnosis. Alzheimer would be another one, which will probably find multiple subsets of people that respond differently. The reason that drug got approved is there were people that benefited from it, but I'm not sure it's across the board. And maybe we could be a lot smarter in how we allocate our dollars for drugs if we find the right populations to treat. I don't know.
Thank you. Thank you very much.
Thank you.
Hi, this is Simin.
Hi, Samin.
Impressive presentation or meeting. You have so many different areas that are applicable. What is your plan for the company? What are your next goals and where are you taking it?
From a company standpoint, our goal has always been, and it's interesting, where you are on the curve of technology. Most of genetics today have been in very narrow vertical areas. So a few years ago, I went to, I won't name it, but a very well-known cancer center, maybe 3 or 4 years ago. And I asked the oncologists there, were they interested at all in pharmacogenomics? And they laughed. They actually laughed at me across the boardroom table and said, ha, 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 that technology isn't ready yet. And one of the other oncologists said, you know what, we're ready. We have about 7 cancers that we have molecular-based treatment, and actually the pharmacogenomics is well ahead. But I turned to those oncologists and I said, certainly you have patients that you treat with pain medicines or nausea medicines or depression, et cetera. And even some of the drugs you use have a pharmacogenomic component to them. And it showed the, I'll say, ignorance of those people at the time. But the other ideas, a lot of institutions now, I'll stick with pharmacogenomics, will be testing for Plavix when they do a cardiac catheterization on a patient, but that's all. So our goal has always been all along to liberate this data and to bring it across the whole institution and not have it be in these little silos. And I mentioned if you were able to do whole genome testing at birth, to have the technology to be able to liberate that all through the system. So we're slowly getting out of these very narrow areas where people say, I'm going to order a 3-gene panel because I'm a cardiologist, as an example, or I'm going to do BRCA testing on a woman that might be at risk for breast and ovarian cancer. And I see Ari shaking his head because he knows that there are now an expanding panel of drugs, of genes that may affect your risk of getting that. So it's a long answer, Samin, to say that as a company, our goal is to really be a broad-based platform that allows this data to be used in many, many forms. We have a technology that sits on top of any electronic medical record in an agnostic way that people don't leave their technology to see what we offer. So if they're looking at a drug list in a certain brand of their electronic health record, our warnings come up despite that. And we're doing that in real time. We're collecting more data, genetic data over time, and we're connecting to more knowledge bases in real time. So we can do that matchup that I talked about with Ari earlier. And ultimately, and this is my pipe dream, as we start assembling more and more of this data, to be able to network some of that data, and because we're only going to make these discovery of rare diseases when we could start doing some of the analytics of patients like this and be able to compare and contrast some of this. But today, our goals are really to just get more widespread adoption of the areas that we know have a huge impact with this. Reducing medication errors alone is a common interest of all of us. And if I could add to reducing adverse drug reactions by adding pharmacogenomics in a routine fashion within people's care, that's a good enough goal for this year. Helping treat cancer is a noble goal as well, but merging those two would be even better.
Great. And do you have the financial resources to do it?
Yeah, we're always looking for new investors, but I will talk about our company. We've been fortunate in that, so we've had a good runway with this. And so it's been a fun ride. But yes, sure, we're always, listen, this is a fascinating time with all this. And as I said, the window here is a very, very small one. And I think a lot of people are trying to do this land grab right now. We've been successful because so many people have been concentrating on the genetic piece of this, the lab piece of this, and you'd see some big acquisitions in those areas. We believe that having this informatics piece at the point of care continues to be fairly unique, but we know that window will shrink soon. And yeah, there's still a ton of work to be done. So if, Samin, you know anybody that's interested in that, we're certainly looking for more strategic investment, of course. Thank you.
Thank you.
Anything else? I'm going to go back to the mundane world of seeing patients in about 3 minutes here. I have somebody waiting, but I'm glad to ask any more questions. Otherwise, it was great talking to you all today. Thank you very, very much. It was a nice break in my days, and it was great meeting new people and having this opportunity. Ali, thank you very much.
Dr. Diamond, thank you very, very much again. It was fascinating, and we're looking forward to see what the future holds on this type of, I'd say, not new, but very exciting approaches to precision medicare.
Thank you so much. I appreciate it. Everybody, have a wonderful day. Take care.
Thank you.
Thank you.
Bye-bye.
Bye. Thank you, everyone.
Bye.
Bye-bye.
Bye. Bye.